Hi guys, welcome back to my channel. Today we'll be starting with gynae. Let us start with the most important topics. First, our gynecological oncology, that is all the cancers of endometrium, then carcinoma of ovary and cervix, and we can also include breast in this. Then carcinoma cervix, the pap smear is really important. Like it comes in almost every exam. The second topic we'll be doing is infertility, followed by the intersex disorders. The next topic would be amenorrhea, including primary and secondary both. And the approach will be very important. I'll be giving you tables. And contraception is another topic which we will do in integration with PSM. So that will be the must know topics for gynae. Okay, so the first topic in gynae will be the cancers in gynae. This is very important topic, and one question or the other is asked in any of the exam. So the first cancer we'll talk about is CA endometrium or carcinoma of the endometrium. What do we need to know in this is that first it is of two types, type 1 and type 2. Type 1 is associated with the corpus cancer syndrome. That includes obesity, hypertension, and diabetes mellitus. It is the endometrial hyperplasia. Then the mutation is PTEN, MLH1, followed by KRAS, that is the microsatellite instability. And then aniridia is also associated with type 1 endometrioid cancer. It can be associated with other mutations like Cowden and Lynch syndrome. So remember the thumb rule that anything, any genetic condition that is associated with some syndrome is always seen in young females. Here as well, type 1 endometrial cancer is seen in young females. Coming to type 2, so type 2 will be seen in elderly. Then the patient will be thin. It will be associated with atrophy, and the mutation here is TP53. Okay. This is the IHC marker for the type 2 endometrioid cancer, and it is associated with poor prognosis since the female is elderly. Alright, so we talked about one syndrome, that is the Cowden syndrome. It is very important. Cowden syndrome is associated with PTN mutation on chromosome 10. What are the cancers associated with it? The first is the endometrial cancer, type 1. We just studied it right now. Second is breast cancer. Third is thyroid cancer. Okay, so how you will remember this? You can always bet on Sachin Tendulkar, yeah? And Sachin's jersey number is 10, right? So PTN, chromosome 10, bet. Bet stands for breast, endometrial, and thyroid cancer. Okay, just remember this mnemonic, bet on 10. One other condition is associated, which is the Lermite-Duclos syndrome. Okay, Then what you need to know in this is the staging. We follow we don't follow the TNM staging here. Okay, so stage 1 is involvement of the myometrium. Okay, let's draw uterus here. Uterus, cervix, these are the fallopian tubes, right? This is the endometrium, myometrium. So in stage 1, myometrium is involved. We further classify it as A and B, where A is less than 50% of involvement and B is more than 50% of involvement. Also remember that along with myometrial, cervical glands are also involved, okay? Only the glands. In stage 2, cervical stroma is involved. Alright. Then stage 3. So you have to remember a mnemonic which was given by Dr. Zainab. She is a great educator on Unacademy. You can check her out. So there is a lady. She's from South Africa. Alright. Who is a vice president there. And she has come to India and is visiting CP. This is the Connaught Place in Delhi. So what is the mnemonic? SA, PP, CP. So in stage 3, SA, that is serosa and the adnexa. These two are involved. Okay, this is stage A, 3A. Then 3B involves VP. V is vagina and parametrium. Okay, and always remember first the upper 2/3 is involved because obviously the upper 2/3 is in contact, so it will be involved first. And C is CP. Okay, remember CP, that is 2 nodes. Okay, so let's continue. So we were on stage C. Okay, so stage 3 is involvement of the pelvic and the para-aortic nodes. Then stage 4. Stage 4 is again divided into A and B. A is involvement of bowel and bladder, while stage B is the involvement of inguinal lymph nodes. Okay, so inguinal lymph node is stage 4C, while pelvic and para-aortic lymph nodes is stage 3C. Okay, so this is 3C and this is 4B. This is very important. Also, stage 4 involves the pelvic wall and the things that we left out in the upper stages, that is the lower 1/3 of the vagina. And hydronephrosis, if you see the buzzword in the question, then it indicates stage 4 of endometrial cancer. Alright, now coming to the management part. So for any endometrial cancer, remember the management is total abdominal hysterectomy plus bilateral salpingo-oophorectomy. That is, you take out the uterus, you take out both the ovaries along with the fallopian tubes. Then we do a post-op radiotherapy along with a lymph node dissection. Now what is to be remembered is where the lymph node dissection is not done. Okay, so it is not done in stage 1, grade 1 and 2. Now how do we define grade? There are 3 grades: grade 1, 2, 3. 1 is well differentiated and 3 is undifferentiated, and 2 is in between these two. Okay, so for grade 1 and 2 and stage 1, what was stage 1? Let's revise it again. Stage 1 was the involvement of myometrium. So in this stage, lymph node dissection is not required. What we do is plain TH plus BSO followed by post-op radiotherapy. Right? Second point, if the tumor size is less than 2 centimeter, then lymph node dissection is not required. So for example, if the question says that there is a tumor of 3 centimeter size involving myometrium, so here we'll see that myometrium is involved, it is stage 1, so we won't do lymph node dissection. That is not true because you need to look at the tumor size as well. Here the tumor size is exceeding 2 centimeters, hence lymph node dissection will be required. Alright. Third point. If the histologically the type is type 1. What was type 1? It was seen in the younger females, remember? And was associated with all the syndromes like Cowden, right? Lynch. Okay. And what was the mutation? PTN, chromosome 10. Always remember this, it's very important. And also there should be no lymphovascular invasion. Right. So lymph node dissection will not be required in stage 1, grade 1 or 2 tumors which are small, that is less than 2 centimeter, in type 1 type of endometrial cancer, which is seen in younger females, and there should be no evidence of lymphovascular invasion. Okay, what do we do in all these tumors then if lymph node dissection is not being done? We do a post-op pelvic radiotherapy, a vaginal vault radiotherapy, okay, and this is to be done for a period of 5 to 6 weeks. Fine. So this was the endometrial tumors. The second cancer we'll start is cancer cervix, which is very important. Now this is one topic which we'll go a little bit slowly about it because it is actually very important, and it comes in every exam, be it AIMS, NEET, right? So let's start with it. Let's do the staging. In stage 1, okay, it is divided into stage A and stage B. Stage 1A is the microscopic involvement of the cervix, and B is the macroscopic involvement. Clear till here? Then we further divide stage 1A into 1A1 and 1A2, which is based upon the size criteria less than 3 centimeter and 3 to 5 centimeter. Then B is further divided into 1B1, 1B2 and 1B3. 1B1 is less than 2 centimeter, next is 2 to 4 centimeter, and then this is 1B3, it is more than 4 centimeter. In stage 2, A is the involvement of vagina, upper 2/3. Remember in endometrial cancer, this was VP, vagina and parametrium, which was being involved in stage 3B. Right, let's check it. So yeah, stage 3B, vagina upper 2/3 was involved, but here since vagina is in close proximity to the cervix, right, so it will be involved in stage 2 itself, and that to stage 2A. Then it is further divided into 2A1 and 2A2 depending on size, which is less than 4 centimeter or more than 4 centimeter. And remember, VP, vagina always goes with parametrium, to 2B will be the involvement of parametrium. Alright, then coming to stage 3, what was left? 3A, vagina, which is the lower 1/3 Stage B, involvement of the pelvic wall. Very important to note here, pelvic wall involvement means stage 3, while in endometrial cancer it was being involved in stage 4. Okay, what was also there in stage 4 in endometrial cancer? What was there? Hydronephrosis, right? So
it's 2 o'clock.
Hydronephrosis, it's already half the day gone, we need to speed up. Hydronephrosis will be involved here, that is, ureters are involved, right? And stage C, this will be the same as that in endometrial cancer. What was that? CP, remember? South African women, pelvic lymph node, and the para-aortic lymph node. Stage 4 is again same. Stage 4A is the involvement of bowel and bladder, and stage 4B is the involvement of inguinal lymph node. So this is the staging of cervical cancer. Let's revise it once again. Stage 1A is microscopic, 1A1 less than 3 cm, 1A2 3 to 5 cm. Stage 2B is the macroscopic, 1B, B1 less than 2, B2 2 to 4, B3 more than 4. Stage 2 is of involvement of vagina and the parametrium. Remember the size criteria, 1A is less than 4 cm, sorry, 2A1 is less than 4 cm and 2A2 is more than 4 cm. Then coming to stage 3, what was remaining? Lower 1/3 vagina, pelvic wall and the ureter, and C is the same as cervical cancer, as the endometrial cancer, which is pelvic lymph node and para-aortic lymph node. And stage 4 is the involvement of bowel and bladder and the inguinal lymph node. Now what is very important is the treatment, which is slightly difficult, right? So we will go step by step. Okay, coming to the treatment part. So first is simple hysterectomy. Okay, what are the types of hysterectomy? Let's do it quickly. Okay, hysterectomy can be of three types, 1, 2, 3. One is known as the simple hysterectomy, in which the fascia of uterus is removed, right? 2 is modified radical. This is also known as Verdheim's hysterectomy. Here what is removed? Parametrium till the ureter. Okay. Apart from that, what else structures are removed in hysterectomy are cervix, right? Uterus, fallopian tube, and stage 3 is radical hysterectomy, which is also known as Meeks hysterectomy. Here, parametrium, fallopian tube, parametrium, lateral to ureter, till there it is removed. Okay, like for example, this is the ureter, fallopian tube, and this is the ovary, cervix. So uterus, fallopian tube, ovaries. Okay, this is hysterectomy. Now based upon what other structures are removed, it is classified into 3 types, 1, 2 and 3. In simple, only the fascia of the uterus is removed, right, along with all these 3 things. And cervix is also removed, and we ligate the vessels close to the ureter. Remember this point in type 1 also, we ligate the vessels close to the uterus, sorry, not ureter. Then stage 2 is Wertheim's, which is the modified radical, in which the parametrium is also removed till where, let's draw this with yellow. Suppose this is the ureter, right? So till here parametrium is removed. This is the Wertheim's. And it makes, what will we do, that even parametrium which is lateral to ureter, that is also removed. Alright, and also it makes upper 1/3 of vagina, and cardinal ligaments are also removed. So what you need to remember is that here parametrium till the ureter is removed, and here parametrium even lateral to ureter is removed in males. So it depends upon the involvement of the parametrium. Fine. Then, okay, so talking about the treatment, let's simplify the treatment first and then we will get into the details of it. Just remember this stage, stage 2B. Okay, so beyond stage 2B, we just do chemotherapy and radiotherapy. Also remember that if the size of the tumor is more than 4 centimeter, then also we will go for chemotherapy and radiotherapy. Okay, so here also we will go for CTRT, and here also we will go for CTRT. The next thing to remember is that before stage 2B, we do hysterectomy. Alright, and what we do is simple hysterectomy.
It's 5 o'clock.
This is type 1 as we studied before, and it can be done up to stage 1A1. Alright, till stage 1A1 we can do simple hysterectomy followed by lymph node dissection, and after stage 1A1 what we go for is radical hysterectomy. Another point to be noted is that if the family is incomplete, if the female is young and the family is incomplete, we can go for a fertility preserving surgery which is called as radical trachelectomy. Now this can be done in tumors up to 2 centimeters, okay, till stage 1B1. So for all these females nowadays, what we can do is we can go for a fertility preserving surgery called as the radical trachelectomy, in which what do we remove? Cervix and upper vagina. Alright, this is very important to note. So I've simplified the treatment a lot, okay. Till stage 1B1 we can go for radical trachelectomy in females who wants to have children. Whereas if the female has completed her family, then what do we do is we go in for simple hysterectomy in stage 1A1. We go for radical hysterectomy in stage 1A2, 1B1, and then we go for chemotherapy and radiotherapy. If two conditions are met, the stage is 2B or more, or the size is 4 centimeter or more. So the third cancer is CA ovary. We're done with endometrial and cervix, and we'll start with ovary. So let's start with the staging as usual. Stage 1A and 1B. 1A is very easy, it is unilateral and bilateral. Okay. C is further divided into 3 types. First is pill outside the capsule. Second is the involvement of surface of the ovary, and 3 is the presence of ascites. Okay, remember that this is an important point. Then coming to stage 2. Stage 2 is divided into 2A, 2B. 2A is involvement of fallopian tube and uterus. B is involvement of pelvis, like bowel, bladder. This is different from both the cervix and the endometrial cancer, as in both of them bowel and bladder involvement was a direct stage 4A. Okay, next is also there is involvement of pelvic nodes. This is also a very important point, because in endometrial and cervical cancer, what was the stage? Just comment down comment down below if you know the answer. I will answer it in a while. Alright, coming to stage 3. Stage 3 is further divided into 3 stages, A, B and C. Stage 3A is the involvement of para-aortic lymph nodes. Okay, so did you write the answer? So in endometrial and cervical both, we know, remember the mnemonic CP? So stage 3C was both pelvic and para-aortic lymph nodes. Here in 2B, pelvic nodes are there. So para-aortic nodes will follow, and then hence they are given in stage 3A. Okay. Also stage 3A comprises of microscopic peritoneal deposits. Fine. Then B and C are dependent upon size. B is less than 2 cm and C is more than 2 cm. Also, liver and spleen capsule involvement would come under stage 3C. Finally, stage 4. Stage 4A would be pleural effusion. Okay. Why this is important again? Because if ascites is present, then it is stage 1. While when pleural effusion is present, it is stage 4. Always remember this point. Okay, so this will be known as malignant pleural effusion. Alright, मतलब ये ध्यान में रखना है पानी कहाँ भर रहा है. पानी lungs में भर रहा है. If the water is being filled in lungs, I mean to say the pleura is outside the lung, this is stage 4. And if the water is being filled in the abdomen, this is stage 1. Very important point to note. Okay, and stage B, 4B will be the involvement of liver and the splenic parenchyma. Right, capsule was stage 3 and parenchyma is stage 4. Alright, now this is a very easy staging, ovarian cancer. Let's revise it again. Stage 1, ABC. A is unilateral, that is one ovary, and B is both the ovaries. C is pill outside the capsule, that is C1. C2 is on the surface, and 3 is ascites. Okay, remember this important point. Then stage 2 will be the involvement of fallopian tube and uterus. Okay, go like this: ovary and fallopian tube, and then here will be uterus. So this is stage 2. Then stage 2B will be the involvement of pelvis structures like bowel and bladder. Alright, and here, because pelvic lymph nodes, because pelvis is stage 2. Remember, 2 is pelvis. Okay, you have to remember this. Then with pelvic bowel bladder, also pelvic lymph nodes will come here. Okay, then coming to stage 3, when pelvic lymph nodes have already taken the place of stage 2. In stage 3, we will see that who will come? Para-aortic lymph nodes. Alright. Then 3B and C, less than 2 cm, more than 2 cm. Also in 3, liver and spleen capsule is involved. And 4 will be malignant pleural effusion. And 4B is livers and splenic parenchymal involvement. Okay, now let us quickly revise their types. Now cancer, ovarian cancer, can be divided into epithelial, germ cell, and sex cord. Epithelial, first is serous cyst adenoma. Okay, it is a cystic lesion. Second is mucinous cyst adenoma. Third, pseudomyxoma peritonei it's not third, this is pseudomyxoma peritonei associated with mucinous tumors. Third will be Brenner's tumor. What are the buzzwords for Brenner's tumor? Okay, remember, this is a wall, alright, and this is the Humpty Dumpty who sat on a wall, okay, and he's having a coffee. I'm drawing so bad. Okay, so this is coffee, and this is wall, and this is Brenner or our Humpty Dumpty. So it will be associated with coffee bean nuclei and Walther cell rests. Okay, and remember, it is a transitional cell tumor. Then there will be clear cell carcinoma. What are the buzzwords? Hobnail cells, and it is a risk factor. Its risk factor is endometriosis. Alright, then germ cell tumors will be yolk sac tumor. The buzzword, what will be there? Schiller duval body or the glomeruloid body. Also remember, it is associated with increase of serial marker alpha fetoprotein. Next is choriocarcinoma. The serum marker is beta HCG. Remember, like in molar pregnancy, right? We generally get choriocarcinoma, and pregnancies associated with beta HCG. So choriocarcinoma will have a rise of beta HCG. Okay, what is the cell of origin of choriocarcinoma? It is cytotrophoblast. Okay, next tumor is dermoid. This is very important tumor because the reason that the examiners like to ask this, it is a very common tumor. You can find it in not every other person, but it is a common tumor in every other person having a cyst in the ovary or a tumor in the ovary. So it will have a solid nodule within the mass. Okay, it will show a fat density. How will you see on CT? Fat appears, this is white, fat appears black on CT. Okay, it is less than 0 Hounsfield unit, generally minus 20 Hounsfield unit, like that. Okay, also if there is a CT picture, there will be a cyst with the fat in it, and it will show some hyperdense teeth like structure. So this is teratoma, which is a mature dermoid. Okay. Also on MR, how will this appear? On MR, in T1 fat suppressed image, we will see again a blackish cystic lesion. Alright. Then another point, what is the paraneoplastic syndrome associated with it? It is limbic encephalitis, which is NMDA associated encephalitis. So what we learn in NMDA associated encephalitis is that it is associated with anti-Yo antibody. We will read more about it in paraneoplastic syndromes. Okay, it's a very high topic. Next is embryonal carcinoma. This is CD30 positive. And finally, we have dysgerminoma. Can anyone tell me the male counterpart of dysgerminoma? Yeah, very good. It is seminoma. Okay, so dysgerminoma, this is the most common malignant tumor of ovary. It is LDH positive. This was a recent INICET question. They had given LDH, alpha fetoprotein, and some more markers, I don't remember, and you have to match them with their tumors. So these serum markers are very important. Alright, then like seminoma, it is OCT34 NANOG positive, PLAP, HCG. Also remember, this is a radiosensitive tumor, right? So if you remember, our cricketer, I don't want to name him, he also suffered from this cancer and it had spread to the mediastinum. But since this tumor has a very good prognosis, and radiotherapy and chemotherapy, helps to get rid of it. Yeah. Next, we talk about the sex cord tumor. Okay, in this we have granulosa cell tumor. This is also associated with coffee bean nuclei. We just read that Brenner's, remember, coffee on a wall, that is also associated with coffee bean nuclei. Then the mutations are FOXL2 mutations. Inhibin I gave the answer. Inhibin is the marker, and the buzzword will be called Exner body, that we will see on the histopath. Right? Second tumor is Fibroma, Thecoma. Now, there are two syndromes, Meeks versus Pseudomeeks. So what you have to remember is that if the tumor is given Thecoma, Fibroma, then it is Meeks, and in Pseudomeeks there is any other tumor except from Fibroma and Thecoma, right? This is a solid tumor and this will be associated with pleural effusion and ascites. Remember, ascites was stage 1C and pleural effusion was stage 4A. Let's check it. Ascites is stage 1C and pleural effusion is stage 4A. Okay. This is how you have to learn. If you forget, then go back and just revise it so that you remember it for a long time. Okay. Third is Leydig-Sertoli cell tumor. Okay, this will be associated with virilization, features of virilization, and the mutation is Dicer1. Alright. Then there is a Leydig tumor, pure Leydig tumor, and in here we'll see Wenck's crystals on histopath. So this was our ovarian cancers. Let's move on to the final malignancy in gynae, and this took me an entire day almost to compile all these things, but this is a very high yielding topic from gynae. CA vulva. Right. What are the risk factors for CA vulva? It is HPV 6 and 11. This is pre-malignant. And what is the pre-malignant condition? Anyone remembers? It is condylomata acuminata. Alright. This can give rise to CA carcinoma, carcinoma in the vulva, which is associated with HPV 16 and 18. Very good. Alright. Then what do? We do Key's punch biopsy and we look at the stromal invasion, because stromal invasion is the most important prognostic factor in CA vulva, right? Also lymph nodes or stromal invasion. They won't give you both options, but remember this point, this is important. Let's talk about condyla acuminata a bit and the other pre-malignant lesions. So condyla acuminata we generally read in derma, and what we will see, there will be a picture given of the vulva and warty cauliflower-like lesions given on the cervix. They can ask which is the HPV that is implicated in this infection and what cancer can it give rise to. Okay, let's talk about the other pre-malignant lesions. So first is Paget's disease. So where do you remember studying Paget's? One is memory of Paget's. Another we read in the Paget's disease of bone. Remember, we have to differentiate from eczema, and then here we read about ivory vertebra, picture frame vertebra, and cotton wool skull. We'll read about all these in ortho and respective topics. Let's talk about Paget's disease of vulva. This is the most common extramammary Paget's. Okay, just remember the memory Paget's. This is not associated with any underlying cancer, that is, it is not pre-malignant. In vulva, although I'm sorry, my English is not supporting me right now. Anyways, so Paget's disease of vulva, on biopsy we'll see pale ovuloid cells in the epidermis. All right, what is the IHC marker? This is important. Cytokeratin 7. Right. Now, next thing that we need to know is the risk factor. It is a risk factor for adenocarcinoma of vulva. And how will we treat it? By doing wide local excision. This is all you need to know about Paget's disease. The second pre-malignant condition is Lichen Sclerosis, and this is very important, as important as condyloma acuminata. Here what you will see is a parchment paper appearance. Okay, the vulva appears very thin, wrinkly, and there will be a figure of 8 appearance. On doing biopsy, we will see thinned out epidermis with sclerosis of the dermis. Okay, so this is like epidermis and dermis normally. So what you will see is that the epidermis
is 6 o'clock
thinned out, and there will be sclerosis in the dermis. Alright, how will you see sclerosis on histopath? Remember that sclerosis appears pink. Right? What else appears pink on histopath? Eosinophils or eosinophilic things. Then remember, what was I about to tell? What else appears pink? Yeah, PAS positive structures appears pink. Right? Remember these extra points. Then also one more thing to remember is that I forgot to mention, rete pegs are absent. What are rete pegs? So normally this is the dermis, right? And these are the rete pegs. So these will be absent again because there is sclerosis, so you won't be able to make out the rete pegs. All right. This is very, very, very important, and the biopsy features of lichen sclerosis have been asked in AIIMS a lot. Okay. In vulva, another important thing to remember is the lymph node drainage. Why? Because here there is a sentinel lymph node, like in testicular cancer. Always correlate and study things. It helps in better retention and better correlation as well. So here, what is a sentinel lymph node? Okay, the sentinel lymph node is superficial inguinal lymph node. Okay, then from superficial inguinal lymph node, it will go to deep inguinal lymph node, which is known as the lymph node of Cloquet. Sorry, and then from there it will go to external iliac lymph node. All right, this is in anterior structures. That is the carcinoma if it is in the anterior vulva. In posterior vulval cancers, what happens is that they will directly go to the external iliac lymph nodes, and these anterior will follow this route. All right, also remember that here we have the clitoris. Okay, so clitoris and the labia minora, exception, they are anterior structures, right? So they should follow this path. But what they do is that if the tumor is involving it within 2 centimeter of midline, right? I'm sorry, if either clitoris or labia minora is involved, or the tumor is within 2 centimeter of the midline, then there is risk of bilateral spread, like bilateral lymph node can also be there. Okay, now let us go to the staging. So stage again, here we follow the TNM staging. So T1A, it is less than 2 centimeters, and T1B, it is more than 2 centimeter. Very important to note is we also take into account the stromal invasion we learned, because this is the most important prognostic factor. And if it is less than 1 mm, it is 1A, and if it is more than 1 mm, it is 1B. Why it is important to know is that it will dictate the management. That is, in 1A we go in for wide local excision only, while in 1B you have to do wide local excision along with lymph node dissection. Alright, or modified radical vulvectomy. Okay, T2, it involves the lower 1/3 of everything: urethra, vagina, and anal canal. Also nodes. Okay, forget this. First let's do the TNM staging only, then we'll integrate it later. I'll tell you what. Then stage 3, T3. T3 is what is remaining: the upper 2/3 of vagina, lymph nodes, which can be ulcerated or fixed. Okay, let's leave out the lymph nodes. We're just doing the T staging. And finally, T4 will be the adjacent structures. All right, then we divide it like we divided the other cancers into stages 1, 2, likewise. So T1A, this will be stage 1, This will be stage 2. Stage 3 is the involvement of lymph nodes, N1, N2, N3, all the stages. This is stage, I'm so sorry. 2 will be 2. This will be stage 3, and nodes and upper 2/3 of vagina. This will be stage 4, right? Also, along with this, if nodes are ulcerated, fixed, and stage 4 will be adjacent structures and pelvic lymph node. Again, like we read, no, not like we read. This is also very different. In all other cancers, we have read stage 4 is inguinal lymph nodes, but here pelvic lymph nodes is stage 4. Okay. Now coming to the management, we already discussed stage 1, we'll do wide local excision plus minus lymph node dissection. In stage 2, we go for modified radical vulvectomy plus lymph node dissection, and all the other stages we'll go for chemotherapy and radiotherapy. Right? Let's revise this again because I think I made a lot of mistakes. So stage 1, less than 2 centimeter, A and B, less than 2 centimeter and less than 1 millimeter stromal invasion, only wide local incision is required. Stage 1B, more than 2 centimeter and more than 1 mm stromal invasion, wide local excision plus lymph node dissection. Modified radical vulvectomy can be or cannot be done. Then 2 is lower 1/3 of the vagina, where modified radical vulvectomy needs to be done along with lymph node dissection. And if anything above that level is involved, like the upper 2/3 of the vagina, pelvic lymph nodes, other structures, then we will go for chemotherapy and radiotherapy. Also, if any nodes are also involved, then also we'll go in for a chemotherapy or a radiotherapy. So this finishes off with the gynecological malignancies. If you have any doubts, you can definitely DM me on my Insta channel, which is NEET PG Mentor. You can also comment below and let me know whether you like the video and what else would you like to learn about or study with me. My Insta page, which is the NEET PG Mentor, I have given the schedule and the list of the important topics, as well as I keep posting, itty bitty things here and there. So follow me on Instagram and subscribe to my YouTube channel, leave a comment and like and press the like button if you find this video useful. Thank you. See you for the next lesson.